All right. Hi, good morning. Welcome to Geriatric's Grand Rounds. We'll start off with just a couple of announcements. The next Grand Rounds is going to be April 30th. We'll have Kristen Allen, a PGY2 geriatric pharmacy resident, speaking with us. And then the next Journal Club, as a heads up, is May 14th, where Mackenzie Garcia and Roman Ayele will be presenting. The other announcements, as always, for every Grand Rounds, you'll receive an email with a link to the recording of today's presentation and also an online evaluation, which if you could please fill out, that helps us understand how we're doing with our Grand Rounds talks. And then submit questions in the chat if you're participating online. Without further ado, I'm presenting Sunny Linnebur. This is a lecture that we always love every single year. She's a professor at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. She's also a clinical pharmacist at the Seniors Clinic, and she served as the president of the American Geriatric Society. This year, we'll be getting her update on medications, but talk about medications, I think, because we didn't have so much new stuff in the pipeline. Yeah, without further ado, Dr. Linnebur.
Thank you so much. As was already stated, normally I would be speaking about what's new, about what are the new drugs for the last year. But we just had such a down year for new drugs in geriatrics, or drugs that we could apply, and that's always my comfort zone, like providing information on new drugs. This talk is a little outside my comfort zone, so. I've been working in the outpatient arena for many, many years, and I'm going to talk about inpatient medicine. So I want to just preface the presentation with, I really appreciate you guys being my test audience for this presentation. And also that if I'm trying to do shout outs in this presentation to our awesome inpatient colleagues. And so hopefully I caught everyone, and I'm able to identify, the major players who were working on some of these initiatives in the inpatient setting. But if I didn't, I apologize in advance that inpatient is not my area. Drug therapy, I'm fine, but anyway, so I'm going to talk about age-friendly health systems, responsible medication management in the inpatient and outpatient settings. And really, I have let's see if it's working here, two objectives. There we go. To discuss the 4Ms framework of an age-friendly health system and the CMS age-friendly hospital measure, which is fairly new to UC Health in a couple of years. And to many of our pharmacist team members and our physician team members. And as a pharmacist, I'm taking the perspective on really providing my thoughts on medication management, because I may come from a totally different focus than you all. So just keep that in mind as well. And I'm going to explore some of our current UC Health and potential methods for UC Health in the future for safely reducing medications that may be high risk or inappropriate for our older patients. I also want to disclose that I was an expert panel member of the AGS-Beers criteria, which is often utilized in our measures for healthcare quality related to drugs. So I've been on the AGS-Beers criteria since the AGS took it over in 2010. And I'm the current co-chair of the 2027 update. So that's exciting. However, I'm biased. And then I was also an expert panel member and author on the Beers Alternatives paper. So I'm coming from that angle as well. So you guys are probably all familiar with the 4Ms and that framework for age-friendly health systems. This comes from the John A. Hartford Foundation and the Institute for Healthcare Technology and Improvement. And when we think about the 4Ms, AGS actually has a 5M. So you probably see that as well. There's that fifth multimorbidity M. But when we think about the quality measures, they use the 4Ms. So the 4Ms being what matters most to that patient: medication, mobility, and mentation. And when you think about the 4Ms, they are really supposed to be assessed in patients, like at the patient level, all together at one time. Because if you're assessing them separately, which we do, but if you're assessing them separately, then like for example, you're making medication changes, you might not know what the patient goals are. And then you might make medication changes that are not always in line with their goals. Maybe they're safer, but not always in line with the patient goals. So when we think about the 4Ms, they really are supposed to be assessed at the same time. Now, CMS has this new age-friendly hospital measure, and this was approved and started to go into effect in 2025. And this hospital measure is to help hospitals take their infrastructure that's already there for age-friendly healthcare and improve it. And this applies to patients 65 and up who are in the hospital, in the OR, or in the ED. The measure is intended to apply only to hospitals who are in the inpatient quality reporting program, which UC Health is. And it requires an attestation that the hospital is agreeing to these certain measures, and I'll show you what those are in a minute, of hospital care, and then reporting of data. That reporting of data will go into the Medicare Care Compare, and I'll show you that dashboard in a second. But when we look at penalties, there are going to be potential penalties for reimbursement, but the penalties are not based on quality, meaning that like if we suck at our age-friendly healthcare, we're going to be on the website, potentially Medicare Care Compare, and we're going to, people can see that, but we're not going to have financial penalties as long as we're reporting that we suck. And I don't think we suck, but I'm just saying, like, if that was the case, as long as we're reporting the numbers, then there's no financial penalty. So the financial penalties are just for not reporting. And I believe the fiscal year 2027 payment determination comes from 2025 data. So it's like the penalties are based on data that was previous. But this is what the Medicare Care Compare website looks like. So if you haven't looked at it before, you can like type in your zip code. You can type in different things you're looking for. And so I just typed in UC Health AMC campus and then VA and UC Health Highlands Ranch. And you can see there's an overall star rating of all three health systems here are 5-star. And then there's an inpatient survey rating where the VA is doing better than UC Health, AMC, and Highlands Ranch. And then there's a whole bunch of other measures that are reported. Now, I only pulled out the one drug one that I could find. So currently, they don't have measures related to the CMS age-friendly hospital measure on Medicare Care Compare. So you can't like look at PIM use on this website yet, but I think they will potentially put those measures on there and we'll see like a percent. But this is about opioids. So the bottom measure, which I copied and pasted in, is safe use of opioids. And so they're looking at proportion of inpatient hospitalizations for patients that are adults who are on 2 or more opioids or an opioid and a benzo at discharge. And the national average is 15%, but the Colorado average is 14%. And then you can see AMC is 15%, so above Colorado, but at the national average. And then Highlands Ranch is at 16%. So you can kind of see that, you know, this is probably what it'll look like for the hospital measure as well. Now, why is age-friendly healthcare important? Well, before age-friendly healthcare was even around, we had data to show that age-friendly healthcare was good, right? But we actually have 2 studies that have come out recently. So in JAGS in 2026, in the January issue on the left-hand side, and in the Joint Commission Journal on the right-hand side, you can see that's a November 2025 publication. 2 different studies looking at outcomes of 4M healthcare in a hospital setting. So on the left-hand side, this is a VA study, and they looked at retrospectively at 2,400 hospitalized veterans that had 4M care during the hospital, and they found a 33% reduction in 30-day readmissions and 5.2% shorter hospital stays compared to those matched controls. On the right-hand side, this is OHSU. So in Oregon, it's an academic medical center, and they also implemented the age-friendly healthcare with 4Ms. They found a 10.4% lower readmission rate, the exact same amount of percent shorter stays, 5.2% shorter stays, and 15.5% lower hospital charges. So already 2 positive studies coming out of this hospital not the hospital measure per se, but going for the hospital measure and meeting the expectations. So these are the 5 domain attestations that a age-friendly health system, which UC Health has already applied to be a couple of years ago. So UC Health AMC campus is mainly what I'm going to talk about today, but the AMC campus applied for this. And so the 5 domain attestations where you're just saying like, yep, we're going to agree to do this include domain 1, eliciting patient healthcare goals. Domain 2, responsible medication management, which is what I'm going to focus on. Domain 3, frailty screening and intervention. Domain 4, social vulnerability. And then domain 5, age-friendly care leadership. So having leadership within the health system. Additional programs can help you meet this hospital measure. So there are 2 different programs that can help you meet it. One is geriatric surgery verification through the American College of Surgeons, and the other one is geriatric emergency department accreditation through the American College of Emergency Physicians. So if you go to these 2 websites and you search, the only hospital in the entire state that has the geriatric surgery verification is the VA. And I mean, you all know that, right? VA is crushing it in this area. And Tom Robinson is right on the website. Our own Tom Robinson, I screenshotted his picture here, but he's right on the website promoting it. And he led that, you know, the VA getting this surgery verification. Now, if you search on the FASCP Geriatric ED accreditation program, there are 11 hospitals in Colorado that have this ED accreditation. Accreditation level 3 is the highest. And there are some UC Health programs that have this, but not AMC. So we can see Poudre Valley on there, MCR, Medical Center of the Rockies, UC Health Highlands Ranch. They all have geriatric ED certification. And the VA does too. So AMC does not have this. So let's talk about then, I'll go into more details on what I think, how AMC is meeting this geriatric 4Ms hospital measure. But let's get into just that 4Ms component and look specifically at medication. So in general, this is not the hospital measure, but in general, when we look at the 4Ms, for medication, what the 4Ms are talking about is if the medication is necessary, so you got to decide if it's necessary or not, you want to use an age-friendly medication that doesn't impact their other 4Ms. So the medication should not impact or interfere with what matters most to them, mobility and mentation across care settings. And this is why you really should be doing them at the same time when you're assessing patients. Again, we don't, but we should be. And when I say we, I mean the whole country. Like, this is not just UC Health AMC. But when you look at the hospital measure and you're looking at domain 2, which is responsible medication management, this domain aims to optimize medication by going through the drug list and looking at inappropriate medications in older adults that might increase harm. And so it's really focused on potentially inappropriate meds, which are PIMS, which are Beers List meds. Now, there are other lists besides AGS Beers List to look for PIMS, like we have Stop and Start. Stop criteria is out of the UK, and so some of the meds on that list don't apply. So most of the time, people are using the AGS Beers criteria, potentially inappropriate med list. But this hospital measure is really focused on PIMS. So they are wanting to make sure that hospitals are reviewing for PIMS on admission before major procedures or upon significant changes in clinical status. And then once that PIM is identified, that PIM needs to be deprescribed or dose adjusted if appropriate. So why is medication management an important part of the 4Ms? Well, as a pharmacist, of course, medication management is important. That's my opinion. But really, we have data to support that too. So there's data to indicate that adverse drug events, or ADEs, are responsible for a significant portion of morbidity and mortality in U.S. hospitals, in the hospital. It's not just on the outpatient side or in a nursing home setting, as well as unnecessary healthcare costs. You know, we're spending money on medications, and then we're spending money on treating the side effects of those medications. So it's like direct and indirect. Also, of course, you guys all know, speaking to the choir here, about older adults being higher risk for adverse drug events. So, they have renal impairment. They're often on many medications and have multiple comorbidities. So all of that is impacting the risk for things like drug-drug interactions and negative effects. And so the avoidance of potentially inappropriate meds or PIMS in older adults has been validated as a quality indicator. And again, that's the AGS Bears criteria. Now, um, I'm interested to see how many of you guys watched the TV show The Pit. We got 2 people. Are you caught up, Jody? Jody, are you caught up on The Pit? Did you watch season? Okay, so Jody's probably, yeah, so she's probably the only one who's seen this episode, but I want to introduce The Pit here to you guys. This is Noah Wiley. He was on the original ED. And Noah Wiley is a physician this is in Pittsburgh. That's why it's called The Pit. And he's a physician in the emergency department. So that's where this, TV show is set. And it's supposedly the most accurate medical drama show so far, and they do have a lot of consultants and stuff. But they're in season 2, and it's episode 12, which was a few weeks ago, and they had some geriatric patients on there. And so you can see Eddie. Eddie is the older gentleman in the screen here, and Eddie, he backed into his wife Frida with his car, and he fractured Frida's hip. And so Frida's in the ED. And their daughter, who's also in that screen, she is a caregiver for them. They live at home. She wants them to move into assisted living facility, and they're just resisting it. And Eddie, if you're old like me, you might recognize Eddie as an actor from Law and Order. So this was, there's a lot of cool stuff going on here. Well, they have a 4th-year resident, Dr. Samira Mohan, which I'm pretty sure she's gonna be a geriatric fellow in this next year. And probably not on the show anymore, but because of that, but she, even though Eddie's not her patient, Frida is, she assessed his balance. And they have a cool clinical pharmacist on this show, Go Pharmacy on TV. We're never on TV. So she assesses Eddie's balance and connects with Dr. Megan North, the clinical pharmacist. And voila, the team reviews Eddie's meds, and they're on the Beers list, and they say this on TV. And they actually start educating the public and say I know Beers list is a list of potentially inappropriate medications for people 65 and up. So here we are in the ED on TV, and not only are they assessing PIMS in the patients, but they're assessing it in their caregivers who come to the ED with them, who are not even their patients. So the team concludes that the meds are likely contributing to Eddie's poor driving and unsteady gait. And the plan for the family, number 1, is to take Eddie off the meds. He's not even their patient, but they're going to go ahead and deprescribe his PIMS in the ED. And then Frida's going to get a physical therapy and an at-home nurse. So my point of bringing this up, this is pretty cool that the Beers list is on a TV show. Go Beers list. But also on TV, they're deprescribing PIMS. So this is doable. If it's on TV, it's real, right? It's real. You might be looking at me like this, thanks, Sonny. I already knew this, and I'm tired of hearing about the Beers list. But if you get your patients off the Beers list meds, look what they can do. She has great balance. She's able to move. She's not unstable. So our patients, they want to be off the Beers list meds. So what does CMS say about strategies that are recommended to reduce PIMS during hospitalizations? Well, they really focus on delirium. And so one of the things that is a big deal is delirium and preventing it by assessing patients and their risk for delirium and due to medication. So specifically to delirium, the drug classes that are recommended in the CMS measure to avoid would be things like benzos, anticholinergics, diphenhydramine, hydroxyzine, H2RAs, sedative hypnotics, and meperidine. They also recommend that the hospital should have processes, protocols, or policies in place to identify PIMS and then to help make with interventions on those PIMS. So for example, deprescribing, de-escalation dose adjustment, alternate medications like the Beer's alternatives list, and then non-pharm adjuncts. So how do they recommend implementing these things? Well, CMS 1 recommends standardized order sets, bundles, pathways to protocolize medication management for older adults. So making sure that those order sets don't have PIMS on them, or if they do have PIMS, remove them and then replace them with safer alternatives. They also recommend having a process for pharmacists to flag and review those inappropriate meds when they're ordered. So the process for reviewing PIMS by pharmacists would be manual, where the pharmacists are looking over the medication list, or there are flags in the EHR and automatically those drugs are flagged. Now, they could also be decision support tools to alert prescribers if you're going to order diphenhydramine, hey, this is a PIM, do you want to order something else instead? And then they recommend education about high risk meds. So like you guys all know about the AGS Beers criteria, but when you go talk to providers in other therapeutic areas, other disease states, they may not have ever heard of it before. And they're like still thinking that we're talking about our Pilsner, right? So I think education is important, even if, that means that we're educating all of you as well. So what are our current strategies to reduce PIMS right now at AMC? I'm going to focus first on inpatient ED and surgery and just go over what I know is available to help reduce PIMS. And some of these things are probably just personal projects for people and not necessarily like a systematic approach, so they may not reach all patients. But the first thing I want to bring up is Sarah Tietz and Tom Robinson worked hard on this delirium report. And so we have in the inpatient setting a delirium report that addresses the CMS recommendation of avoiding meds that induce delirium. This is a pilot initiative currently on 3 units, but anyone can access the delirium report, meaning like if you're an ACE provider or you're, a provider in a different, like you're in endocrinology, you can still access the delirium report. And what this looks like is you go to Snapshot, because I actually did this myself. You go to Snapshot and you type in delirium report and it'll just add it onto your profile. And then you can see, so like in the delirium report, there's a whole bunch of stuff you can see on the screen and this is a fake patient from the play environment, but there are a lot of things that are on here about delirium, including mobility and stuff like that too, and lines. And then you can, if I zoom in, there's a section on high-risk meds. And so it'll pull up any high-risk meds that the patient has. And to avoid those medications, it says consult pharmacy if on high-risk meds for alternatives. So I ordered on this patient in the play environment diphenhydramine, 100 milligram, it pops up. You can see the patient also is on alprazolam, cyclobenzaprine, and prednisone. So those are all high risk for delirium. And this is something that I'm not sure how many people use, but I found it very helpful, and it directly meets that recommendation from CMS about the age-friendly delirium review. We also have a standardized order set. So if you didn't know, and thanks to Dora for screenshotting some of these things, we have a geriatric general admission order set, but no one uses it, is what I heard. So we have a lot of people using general medicine order set. Some of the differences between the geriatric general medicine order set is that some of the PIMS are removed. So you can see here, well, you probably can't see because it's so small, but acetaminophen is the preferred pain medication on the geriatric gen med order set, whereas on the regular one, you have acetaminophen, NSAIDs, muscle relaxant, oral opioids. And if you click on those, it'll give you drop-down options, obviously, and IV opioids too. There are also a few other differences, like, for example, antiemetics. On the geriatric one, it's ondansetron. On the Gen Med one, it's on Dancitron preferred, but then prochlorperazine is on there as well. And we also see on the antipyretic side, on the regular order set, that's left off the geriatric order set. But on the regular order set, there's cetirizine, which again says preferred, but you can pick hydroxyzine, you can pick diphenhydramine for an antipyretic. So when we think about the order set, I really like this geriatric order set. I'm not sure why people aren't using it, but there's no pop-up or anything that tells you it's even available. We also have Agile MD pathways, and Laura Mackey works on all these different pathways, but this is the one inpatient acute care dementia and delirium. And if you like zoom in, within here, this left-hand side has a path. If you have dementia already, then you go down a different path for that delirium. And this side has, if you're over 64, then you go down this right-hand side. So the drugs are more tailored towards that older adult. So pathways are another way that CMS recommends to address medication management. Then we have DORA. So most of you probably recognize Dora, but she is one of the pharmacists that are full-time UC Health employees, and Dora rounds with the ACE team. So when we think about the options for pharmacists reviewing medications, which again CMS recommends, there is a process for all pharmacists to review orders, but for the non-ACE teams, it's just order verification and appropriateness there. So you're really relying, because there's no pop-ups or EHR modifications, you're relying on the knowledge base of the pharmacist or the comfort level of that pharmacist who probably doesn't have geriatric training. And then on the ACE service, Dora conducts daily medication profile reviews Monday through Friday, and she makes recommendations or identifies the PIMS to the team either during rounds or multidisciplinary meetings. Also, we have our geriatric surgery and aging surgery wellness program. So Dan Adams, I think, is a PA that is organizing that. Tom's on it too. Then we have Dr. Walker and Dr. Tietz who are also working on that and providing feedback. And that's really a multidisciplinary review of patients pre-op, and they are working on modifications on the post-op order sets, but as far as I know, those order sets haven't been adjusted yet. Then we have the VESPA team. So VESPA, is not completely focused on drug therapy, obviously. VESPA is about identifying victims of abuse and supporting their care, but there are patients who are being abused with drugs. So for example, the VESPA team saw a patient who came in from the assisted living recently with reports of sexual assault after being given an unknown medication that made her drowsy on multiple nights by the same staff member. So drugs do come into play there. And that's, we have Dr. Tietz, Dr. Bloman, Dr. Boland, and then Sarah Cox, who's a social worker, works on that team. Then we have our geriatric ED consults. And I put a star here because these are star people. No, of course they're star people. All of you are star people. But I put a star on here specifically because they really review all 4 M's at the same time. And again, that's our ideal scenario, is reviewing all 4 M's. So we have Dr. Runkle, Dr. Bellantoni, and Dr. Boland working on ED consults. And this is just like a screenshot of a note that Dr. Bellantoni wrote about one of our patients. And I have the red box here just focused on medication, but you can see that she was writing about mobility, medications, mentation, multi-complexity, and what matters most. And so all of those things are in that note template that really help us identify, and specifically about medications, what might have led to that patient having an ED visit. Then outside of AMC, we have Elizabeth Goldberg, who has an NIA-sponsored R21 grant and is called eGap Care. And so I work on this project with her, but it's implemented at MCR. So basically what happens at MCR is patients will come in with a fall, older adults. If they are eligible for the study because they're not admitted, then a physical therapist and a pharmacist will review the patient for for changes, potential changes. So the pharmacist looks at their medications and makes recommendations about changes. And this is pretty much related to PIMS and then CDC's study. Also coming soon, Elizabeth has Gap Care AD, which is an NIA-sponsored 5-year R01. This will be implemented at AMC. So that's going live at 3 different sites. It's going to start in November. So at AMC, at UMass, and at WashU in St. Louis. And this is going to be pretty similar protocol where a pharmacist is going to review the medications in these patients to reduce repeat falls, ED visits, and caregiver burden. But all of these patients will have dementia. So they're being, they may have a slightly different drug review because it'll include not only falls, but also dementia. So what are the current strategies in the outpatient setting to reduce PIMS? Well, as a pharmacist team, Danielle, Dory, and I will write transition of care notes. We have a protocol to manage with chronic care management, diabetes and hypertension, osteoporosis, and we also perform annual wellness visits. So I'll just start on our annual wellness visits here on the side. I have some example recommendations, but we realized we were not asking what matters most. We were asking about falls, we were asking about mentation, we were of course looking at drugs, but we weren't asking what matters most, so we added that. It's not required by Medicare, but we added it to our note template. And honestly, like last week when I saw a patient for an annual wellness visit, it changed my plan because the patient had been on mirtazapine for insomnia, and the patient had gained some weight, and they already had pre-diabetes and they were overweight. And so they were on mirtazapine for insomnia. We have weight neutral meds for insomnia, right? So I was like, maybe we should switch this patient to a weight neutral med like Ramelteon, which is a melatonin agonist, or Adora, Dayvigo. So I had that recommendation, but then I remembered, got to ask what matters most. And when I went over what matters most, this patient, for him, sleep mattered a lot, and the mirtazapine was working. So I was like, forget about this. I wrote, later, maybe we could consider, if it's not working, we could maybe consider changing the mirtazapine, but it wasn't causing that much weight gain. He had gained like 4 to 8 pounds over a year maybe. So it wasn't that significant, but I changed my recommendation when I asked him about what mattered most. And then you can see this other example note was, sometimes we have a lot of recommendations. This was about this one on the right-hand side was a patient who was on Xarelto and aspirin and also on prednisone. And so high risk of GI bleed. Patient didn't need aspirin because it had been several years since their last coronary intervention. And they also were on too high a dose of Xarelto for kidney function. So when we think about their optimization and Xarelto is a PIM, theoretically, it's on the Beers list because it has higher risk of GI bleeding and major bleeding compared to other DOACs. And this just came out even with VTE treatment, the COBRA trial. COBRA looked at acute VTE treatment and compared rivaroxaban to apixaban, and rivaroxaban had significantly higher bleeding risk, even acutely, than apixaban. So anyway, we make PIM recommendations in annual wellness visit. And then on the left-hand side is a patient with TOC Rex. This patient has been in the hospital or in the ED 20 times in 18 months for a lot of different reasons, but they also had 2 separate ED visits and 2 separate hospitalizations related to falls and had some fractures, and they're on Ambien 10 milligrams, tizanidine 2 milligram, but taking it daily, and then pregabalin 300 twice a day. Pregabalin's not a PIM, but pregabalin is, it could be, but it's not. And the patient's renal function, the dose that was recommended based on the package insert is half of what that patient's taking, and they're falling regularly. So, we're making recommendations there about those meds. So we also have a falls clinic, Dr. Johnson, who has a falls clinic where they're looking at medications that can increase the risk of falls. And again, both in the ED or in the outpatient setting, falls have huge morbidity. So it's important to identify if medications are contributing. Then we have the geriatric oncology and hope clinics, which are focused on tailoring the care to what matters most to the patients and safe medication management. Devin Gilhooly is working on both the geriatric oncology and hope clinic, and we have Sophie here who's also working on that geriatric oncology clinic. This was just like, this picture I got was just highlighted last week in a UC Health or campus promo for this clinic. So lots of stuff going on. We also have the guide model, which we have Dr. Hildreth and Dr. Lum, who are working on that improved dementia experience. This is a Medicare innovation model of coordinated and comprehensive care. You guys already know all about it, but it really helps not only with coordination of care, but medication management and reconciliation is included as part of that process. So what are some opportunities and what does our PIM data look like? So I was lucky enough to get some data related to our hospital PIM use. So this is back to inpatient. And when we look at the PIM use in the hospital, we have these are the ones where we're not doing as well as other hospitals. So there's lots of meds, of course. We're doing pretty well on some of them, and even a little slightly better than median comparable hospital for benzos. But when we look at conventional antipsychotics, 17% of our older adults in the hospital in 2024 were on one of these agents versus only 6% at a comparable hospital for the median. First gen antihistamines, 17%, comparable hospital, 11%. Skeletal muscle relaxants, 15%, 5%, comparable hospital. Ketorolac, that drug does work. It's a pretty good drug, but it has a lot of side effects, GI bleed, kidney impairment. 13% for our older adults, 8% for comparable median hospital. So we have some drug classes and drugs that maybe we need, could take a deeper dive. We also, the report also looks at like drug disease interactions. And so this is where, like, for example, most of the numbers were 1% or so, 0, even some of them. But you can see with delirium, dementia, or cognitive impairment and falls and fractures, these were all quite a bit higher. And so I pulled these out. They don't look that high, but they're higher than everything else. So that's why I pulled them out. So you can see anticholinergic meds, 3% of patients who were delirious were on them. 2% were on them that had dementia, 3% with a history of falls and fractures. So you see probably if you're going to compare, like there's 4% on opioids. So opioids may be an area we could work on here. So some opportunities to take action. These are my own opinions as a non-inpatient provider of things that we could do to maybe work on our responsible medication management as an AMC hospital. So one, I think inpatient providers could be educated about using the delirium report to identify and eliminate PIMS related to delirium. So it would be awesome if the whole hospital used the delirium report to identify and predict and eliminate these drugs that can contribute to delirium. It's not that hard to do. You go to your snapshot, you add the delirium report, and then you have to look at it and you have to still assess. But what I was also able to gather from our data is that we have some service lines that have high PIM orders in those categories that I was talking about. So when we think about the service lines, they could potentially remove and replace these PIMs in their order sets. I don't think that necessarily we have to use the geriatric order set. I think there's some like low-hanging fruit here on order sets. Just like no one needs some of these PIMs. It doesn't matter if you're 40 or you're 80, like who needs diphenhydramine? Now you may be like Sunny, some people need diphenhydramine, and I'm gonna try to figure out. I tried to figure out like when are these drugs gonna need to be used, but I couldn't even come up with any scenarios. So when we think about conventional antipsychotics, the number one team ordering those is general medicine. We also see oncology number 2 and general surgery number 3. First gen antihistamines, we have general medicine, then we have oncology, then we have spinal surgery. You know you want someone who had spinal surgery to be on Benadryl, right? No, you don't. And then we have skeletal muscle relaxants, spinal surgery number 1, oncology number 2, and gen med number 3. Then ketorolac, we have oncology number 1, spinal surgery number 2, and gen med number 3. So, and again, this is just my view here, but when I look at this, there are some similarities. Like oncology maybe could use some extra review of whatever their order sets are. I think sometimes it could be easy to just check stuff off, even if the patient doesn't need it. So one of the things that I'm recommending is reconsidering some of the PIMs on all the medicine and surgery order sets, along with education. So first-gen antihistamines. Why do we need diphenhydramine? What is diphenhydramine being used for? Is it being used for itching? Because if it's being used for itching, that is a prescribing cascade, right? You want to stop whatever's causing the itching. If it's being used for insomnia, we have much safer medications, and melatonin is even on the general medicine order set as the first-line agent. Maybe people don't want it, but we have Ramelteon, which is cheap, melatonin agonist. We could use something else. Is diphenhydramine on there because of an allergic reaction? Maybe, but guess what? Cetirizine also treats allergic reactions. So we can use, or maybe you don't order it, the diphenhydramine, and you wait till they have an allergic reaction. And it's not just automatically ordered. So, you can order stuff that aren't on the order set. So if we just take it off the order set, then it's not auto-ordered. I feel like some of these are auto-prescribing cascades. Prochlorperazine, why do we need prochlorperazine on any order set? Who needs that? I couldn't come up with any reason for prochlorperazine because we can use other anti-nausea medications like ondansetron. Now, ondansetron, you have to worry about QTc prolongation, so there might be a few patients, but even in those patients, you could just order something else. You don't have to have prochlorperazine auto-ordered for our older adults or even a 30-year-old. And then we have skeletal muscle relaxants. Personally, I think skeletal muscle relaxants are overused in protocols. Patients go home on them, and they don't even have any reason to be on a skeletal muscle relaxant. There's no actual muscle issue that they are having spasms or something. It's just in case that happens. Well, in case that happens to a patient might mean I guess I got to take it. And so let me just give you this patient example. This was a TOC I did it a month ago, where he's 92, he's really spry. So he rides his bike, and he had a bicycle accident, and he had a left hematoma, or left hip hematoma, and he was discharged on tramadol and methocarbamol. And so methocarbamol is a skeletal muscle relaxant. It's on the Beers list. All of the skeletal muscle relaxants can cause sedation and dizziness. He didn't even take the tramadol because his pain on Tylenol was 1 out of 10, but he took the methocarbamol because he thought he was supposed to. And these were his words. He said, I'm not taking it ever again. It made me feel weird, in another orbit. My eyes wouldn't focus. I was very tired. And even I have talked to other people I've never taken these skeletal muscle relaxants. I think in pharmacy and med school, we should all take these meds and see what happens so that we can see we're young, and here, I'm getting older, but what happens if you're young? So for example, I was talking to one of our providers in the seniors clinic who took 5 milligrams of cyclobenzaprine because they had muscle spasms, and they had to go home from work. They couldn't work because of the fogginess and clouding of the brain. And so why would we do that to our older adults who have less cognitive reserve? It's just insane to me that we order these skeletal muscle relaxants. They're just on auto order. I don't get it. So I think that skeletal muscle relaxants could be ordered if they vary, in the very specific cases where they're actually indicated, and not auto-ordered in our order sets. Sorry, I went on that rant. Some other opportunities to take action, we could consider applying at AMC for the Geriatric ED accreditation program or geriatric surgery verification. I really think we need some education for our inpatient pharmacists on PIMS and the PIM data so that they are maybe more at the top of their mind and more structure for reviews outside the ACE team, because of course Dora is only one person and she's only reviewing the ACE service, and we have tons of other patients outside ACE. And then your favorite, I know you guys are like super pumped about me saying this, decision support tools in the EHR can be very helpful for alternatives to PIMS, like for example, the AGS Spears criteria alternatives list. So if you haven't looked at this pub, there's a lot of alternative drugs and non-pharm for drug therapies in all of these different categories. So, like here we have allergic rhinitis and pruritus. What else could we do besides hydroxyzine? We don't have to use hydroxyzine. And then, when we think about like this is just what's included in the insomnia category, but when we have a patient who has insomnia or sleep issues, we may turn to some PIMS like benzos, Z drugs, first gen antihistamines, tricyclic antidepressants. And what are some options instead? So the alternatives include things like low dose doxepin up to 6 milligrams, or some of the dual orexin receptor antagonists, or Ramelteon, which is generic and super cheap. And so when we think about these options, we have options, but specifically there's insufficient evidence to recommend trazodone, mirtazapine, melatonin. So, we could consider other agents even compared to those. Also, recently in JAMA, this year, 2026, a study came out looking at electronic health record interventions in the outpatient setting and deprescribing. This study took older adults in Boston who were over 65 and on at least one benzo or one non-benzo sedative like zolpidem, and or 2 or more anticholinergic medications, and they randomized their PCPs to an EHR pop-up about deprescribing. And the primary outcome was deprescribing at least one of those medications, the benzo, the non-benzo, or an anticholinergic, after that first patient visit through the end of follow-up. And what they found was that there was a significant, like an absolute increase of about 10%-ish on that EHR pop-up, helping PCPs remember to talk about it with patients, to deprescribe, and then also actually deprescribe. Some additional ideas, this came from an AAFP CME about age-friendly healthcare, is that some institutions have a dashboard now. So a 4Ms dashboard, kind of like that delirium report, but this dashboard has all the 4Ms included on it. You can see like delirium risk here on mentation. There's a little gauge. We have mobility. Maybe it hasn't been assessed or it's not good. And so there's lots of ideas on things that we could do to really take action to improve our patient care. Now, last night I went to the Mel Robbins tour. So if you're young, you don't probably know who Mel Robbins is. If you're old, you probably do. Mel Robbins is a speaker who is I think she's like the number 3 podcaster in the world. And she has this book called The Let Them Theory. And this is an awesome book. The theory is really great. Let them. Basically, you're giving up, you can't control other people's actions, right? So you just let them do what they're going to do, and you let me do what I'm going to do, and you control yourself. But I want to like pause here and say, like, this book does not apply to PIMS. I'm not going to let them order diphenhydramine. I don't want to let you order, a benzo. But one of the quotes she has, and she said this last night, is if you do nothing, nothing changes. So I just want to leave you with small things. She also says small things are not small at all. They are the most important things of all, and they add up. So even small things that we're doing, and Sarah, you missed it when I talked about the delirium report, but like that was a small initiative, small quote, initiative that Sarah and Tom started, and I think it could have big implications for our whole hospital. So I would encourage you guys to continue thinking about small things that we can all do. And I just want to say thank you to all the people that helped me with these slides and gave me information about what they were doing and patient case examples. And thank you guys so much. I think we're out of time. or close to out of time. Elizabeth.
Thanks, Sunny. This is semi-related, but any idea of how SSRIs are going to land on the next iteration of the Beers list? I think that's one of the more controversial meds.
Yeah. So when you talk about SSRIs, are you referring to like any idea that they might get taken off?
Yeah.
No.
Or like,
I don't think that's happening. So SSRIs and SNRIs are on the Beers list from the perspective, they're on the disease drug interaction one where due to SIADH. So that's really related to, antidepressants can cause SIADH. And when we think about older adults are more likely to have that. So it's more about like screening. Now, I think we will probably make some wording changes to the criteria where it's more about like monitoring. It's not that you wouldn't want to use an SSRI, but you need to monitor for low sodium. They're also on the falls, the drug disease for falls. And when we look at antidepressant data, it's pretty robust at increasing the risk of falls, like on their own, without any other risk factors. So, I mean, again, that's more about monitoring. So that wording could change a little bit on the monitoring, but I don't see the antidepressants coming off the list related to falls because there's so much data to support them. The one thing is that, when you think about risk benefit, the risk for someone of falls may not outweigh the benefit of the antidepressant. But what I have found is that asking patients about their antidepressant, like maybe they're on it for 10 years and they don't really need it anymore. And sometimes we just kind of forget to ask them again about, why did you start this? How are you feeling now? And I did just ask an annual wellness visit patient not that long ago about her antidepressant. And she was like, I don't know, I've just been on this forever and I feel great. Now, she might feel great because of the antidepressant. It's hard to know. But I think it's just a pause for us to remember to ask patients and reevaluate, all meds, but especially those where we may not be, the patient may not be complaining about anything and they're just staying on a med for a long time. And we do have opportunities, to taper off those medications, see how the patient responds. But I still think that is a good option if the patient doesn't need it, just to reduce their risk of not only falls, but hyponatremia or QTC prolongation with citalopram or escitalopram, and just overall medication burden. I don't know. All of this takes time, and that is never on our side, time. But I try to approach every patient. I'm only in clinic on Thursdays, so it's not that bad. But I try to approach every patient like if this was my grandmother, what would I want her care to look like? And so I'll spend more time. I spend more time because I have one day of clinic, so it's not that hard. But
thank you so much, Sunny. And I'm just sitting here thinking about surgery. It's standard of care to prescribe gabapentin and methocarbamol. And it doesn't matter if you're 65 or 95, you are getting that as your post-op medication. On your post-op medication regimen. So I'm just curious about the pharmacists who are in that realm. They have your training. I mean, they're not geriatric specialists, but they know that this is not okay in older adults. So I'm just curious what the relationship is between general surgery in particular, or spinal, as you point out, or ortho, and is there a discussion about older adults and what can be done in terms of consultative pharmacy?
Yeah, that's a good question, Carrie. I actually don't know if they really know. I really don't. I teach these drugs, so does Danielle, in pharmacy school and trying to avoid them in older adults, but I don't really know where they hear about that again after pharmacy school. And that's just CU pharmacy students. I don't know about other universities, but I personally, I don't know that the pharmacists that are, filling these prescriptions or processing the surgery orders are really thinking about like, could be harmful. I think they're just thinking like this is standard of care. And I don't know why it's standard of care. Like, I mean, if you think about the muscle spasm stuff with like the skeletal muscle relaxants, how many of the patients actually get spasms? And we're just ordering it for everyone in case. It's like this, there are a lot of correlations with other professionals like dental pain. Dentists will just prescribe everything so that they don't have to get a phone call. And that's sometimes what happens, but that doesn't mean that's good. And I honestly think we should like go back to the drawing board and be like, do we actually need skeletal muscle relaxants as standard of care? Is it really necessary? Or should we just order it for specific surgeries where we know that they probably will have spasms, or they had them post-op in the hospital, and so we know they're having them, and then we order more appropriate drugs. Like, I mean, sometimes even baclofen might be more appropriate than Flexeril. Ugh. So like, I don't know. I feel like we need to go back to the drawing board and like actually think, is this necessary? I don't know that they are. Gabapentin, unfortunately, is not on the PIMS list, but gabapentin has its own issues too. And gabapentin skeletal muscle relaxant could like knock out someone's brain.
I mean, I
days.
think it's challenging as one of the people on our aging surgical program. The surgeons all have very good intentions and are trying their best to do what's best for our patients. And we aren't the ones who are seeing the patients writhing in pain after surgery.
Mhm.
And so I think it takes some relationship building over time and some gaining trust over time. We aren't inpatient. And so it's really easy to Monday morning quarterback and say, well, they shouldn't have been on this or they shouldn't have been on that. But I didn't see that patient there.
Yeah.
And oh, yeah, I know. I don't agree with the approach, but I think that I don't agree with the approach of giving everybody gabapentin and methylcarbamol, which is what's happening with particular order sets. Every single spine surgeon has their own order set. So this is not like changing one order set. This is changing thousands of order sets throughout our system. So it's a huge undertaking. But I guess I think that the approach of making change will come from partnership, trust, believing in that surgeon and that they want the best for their patients, and not come from, I know better and they shouldn't be on that. And I'm not saying you're saying that, Seti.
Yeah.
But I think like in general, as we started, I was like, we should just change your order sets, tell those surgeons not to do that. And that approach is not well received. And I didn't take that exact approach, but I think being a good partner, caring about the things they care about, and then making small suggestions and changes over time, I think is going to have a much bigger impact than telling them what they shouldn't be doing.
Yeah.
'Cause
100%. Yeah.
It's really tough. And they just have a different lens of how they view the care that they're giving. And so like trying to get in their mindset of how they view the care they're doing and slowly adding our things, like Elizabeth, I know is working on a presentation to not give Atarax, that it's like, if that's the one change we can make this year, great, we'll have less Atarax and then we'll make smaller changes.
That's right. And that goes back to this comment. Small things are not small at all. They're important and they add up. So like chipping away at some of these things. Yes. I think what will help too is if the Medicare Care Compare puts some of these drugs on the list and we look bad, we might not, we might be fine. But if we do look not so good on the Medicare Care Compare, then maybe that will be some more motivation for a system level change, at least reevaluating.
There's a question online. I don't know if Alex, you want to unmute?
Yeah, at this time. So talked a lot about Beer's criteria, and you mentioned kind of anticholinergics during, and even in that PIT episode, they mentioned anticholinergics. And I was wondering if you see value in using anticholinergic burden at all as the identification of when someone should be deprescribed or having their medication modified.
Yeah, that's a great question, Alex. The anticholinergic burden scales, there are a lot of them. And a recent review just came out in JAGS maybe a month ago that reviewed all of the different scales to really figure out, is there one that's best that we should use? And the result of that review was that there's not just one, there's not one best anticholinergic burden scale. So at this point, I think, if we did use, there's an updated one that I think would be reasonable to use, but when you look at the anticholinergic burden scales, usually the highly anticholinergic ones are like a 2 or a 3 on that scale. And then we have a ton of ones where there's mild anticholinergic effects. And those kind of, if you're looking at the scales, it's intimidating because the numbers are so high of drugs that are 1. And so I think sometimes that will really cloud people's opinions about using one of those scales. So I do think it would be great to have, an assessment of that somewhere in our system. But what I find clinically is that patients, you can easily identify them just by looking at the med list without having a burden number, a quantitatively measuring it. So for example, if you had the scale, and the scale, you get a number and it's like a 5 because you had a 3 and a 2, you're going to try to get the patient off one of those anyway. You already know what are the high risk anticholinergic meds like oxybutynin or diphenhydramine. And so the number doesn't help you clinically, I don't think. I don't see that number helping, because the drugs are the ones that the drugs you already know are the ones that are high that you'd want to identify. And if someone's on, something like loratadine and it's a 1, for example, I'm not going to try to get them off loratadine when they're on a 3 like oxybutynin. And even if they're on loratadine and it's a 1 and that's the only one they're on, that's probably not that big of a deal. So I think the scales are nice for research. Clinically, I don't know if they're that helpful, because the quantitative measurement of it doesn't really mean anything to me. And I already, but looking at the drugs themselves does matter, and looking at the high anticholinergic drugs can be helpful as well.
Terrific. Appreciate that insight.
Thank you, Dr. Linnebur, for that great talk. Remember, everyone, please fill out your forms, and we'll see you at the next Geriatrics Grand Rounds.
Thank you.
Thank you.